Okay, so good morning. So for today, we will have one of the most important topics in bacteriology, and that is about Mycobacterium. So when you say Mycobacterium, this of course this pertains to acid-fast bacilli. So this is the general rule. So the general rule is that all bacteria are non-acid fast except for Mycobacterium. Now, there's another genera or another genus of acid-fast bacilli, and this is Nocardia, which I have discussed in gram-positive bacilli. Nocardia is an example of slightly acid-fast bacilli. So the real acid-fast, the legit acid-fast, okay, we call it Mycobacterium. So sila talaga yung mga legit na acid-fast. Okay. So if we will be looking at the general characteristic, why do we call it mycobacteria? So the reason why we call it mycobacteria is because of the fact that they have mycolic acid. They have mycolic acid in the cell wall. So if you will be looking at the cell wall of acid-fast bacilli, one of the things that you will see that is quite unique for them is the presence of mycolic acid. And mycolic acid, take note, is very high in lipid. And this is the reason, why this makes the microorganism waxy. Okay? And this is the reason why it is hard to stain using gram stain because it is waxy. Since it is waxy, it is hard to stain. And in order for us to stain them, we can use a special type of staining. It's another differential stain, and we call it the acid-fast stain. So, acid-fast stain. Although if we will be staining it with gram stain, they will be classified as gram-positive. But it's quite difficult to stain them using gram stain. So most of the time, we would opt to stain them using an acid-fast stain. Okay. So if we will be looking at the morphology of the mycobacteria, they are non-motile, slender, slightly curved, rod-shaped bacilli, and they do not have spores. And of course, they would require complex media. Okay, so later on, we will be discussing that there are two types of culture media. Okay, there are two types of culture media for Mycobacterium, and these are the agar base, and the other one is the egg base. Okay, so we have the agar base, and the other one is the egg base. Okay, so moving forward, let me explain to you the principle of acid fast stain. Why do we call it acid fast? Okay, acid fast means that the ability to resist decolorization by acid alcohol. Okay, so that's what we meant by acid fast. So the word acid fast means the ability to resist decolorization by acid alcohol. And what is an acid alcohol? Acid alcohol is the decolorizer in gram stain. So It is a decolorizer in gram stain, and it is made up of hydrochloric acid plus alcohol. Sorry, not gram stain. Let me correct myself. Decolorizer in acid-fast stain. Okay, decolorizer in acid-fast stain, and it is made up of hydrochloric acid plus alcohol. So usually there are two methods of doing acid fasting. So you can either do the Ziehl-Neelsen method and the Quignon's method. So there are two ways of doing acid fasting. So the Ziehl-Neelsen method is also known as the steam method. The Quignon's method is also known as the cold method. The reason why we call it steam method, because if this is your slide, and then this is the alcohol lamp, and then this is the sputum that contains a specimen, you need to heat the smear. You need the you need to allow you need to allow the smear to pass through alcohol lamp. Okay, so that is the steam method. And then Quignon's method, there's no steaming. Okay, so question, why steaming is important? Remember that the cell wall is made up of mycolic acid. Okay, and what is a mycolic acid? Mycolic acid is waxy. And since mycolic acid is waxy, it is impenetrable. It's hard to penetrate the cell wall because it is waxy. And in order for the primary stain, which is the carbolfuchsin, to penetrate the cell wall, we need steaming. So the purpose of steaming is to allow carbolfuchsin to enter the cell. Okay? So that's the purpose of steaming. So the purpose of steaming is to allow carbolfuchsin to enter the cell. Okay? But the other method is the Quignon's method. Quignon's method means there's no steaming. Okay? There's no steaming in Quignon's method. However, instead of instead of steaming, we increase the concentration of carbolfuchsin, we prolong the contact of carbolfuchsin, and we adding wetting agents such as tergitol. And this is the reason why there is no steaming in the cold method. Okay? So nonetheless, both of these method utilizes primary stain. Okay, so the primary stain is carbolfuchsin. So what is the purpose of carbolfuchsin? The carbolfuchsin, the purpose is to stain the cell wall of the Mycobacterium. And then, after adding carbolfuchsin, we add the decolorizer. So our decolorizer is an acid alcohol. So acid alcohol is made up of hydrochloric acid plus alcohol. For non-acid fast, it will be decolorized. But for acid fast bacilli, it will not be decolorized. And then we add the second stain, which is the secondary stain. Okay? So if it's an acid fast bacilli, it will not take up the second stain because it was not decolorized by acid alcohol. But for non-acid fast bacilli, it will take up the counter stain since it was decolorized by the acid alcohol. So I hope you will remember what I said. For acid fast bacilli, it will not take up the counter stain because acid fast bacilli were not decolorized by acid alcohol. But for non-acid fast bacilli, it will take up the secondary stain or the counter stain because they were decolorized by the acid alcohol, which is the decolorizer. Therefore, you would expect that the color of non-acid fast bacilli is blue since the counter stain is blue. And the color of non-acid fast bacilli using the Kinyon's method is green since the counter stain is a malachite green. So I hope that's clear. Okay? But for both Ziehl-Nielsen and Kinyon's method, the color of the acid fast bacilli is red or sometimes fuchsia or sometimes pink. But baka mamali pa kayo sa exam kapag fuchsia kasi mahirap i-spell, pink na lang. Ayan, or red/pink. Pero talaga, fuchsia, pink. But nonetheless, it depends on the intensity of the stain. Okay. So this is an example of an acid-fast bacilli. So you would notice that this is an example of a WBC. WBC took up the methylene blue because the WBC is non-acid fast structure. Whereas acid-fast bacilli is somewhat red or pink or fuchsia pink because it took up the carbolfuchsin. Okay? So they are strictly aerobic. So when we say strictly aerobic, they would be requiring oxygen for them to grow. They are slow growers. Those associated with disease would take about 2 to 6 weeks to produce growth. So, or for example, S. aureus, if you'll be incubating S. aureus, after 24 hours of incubation, you would now be able to see visible colonies. But for Mycobacterium, it will take about 2 to 6 weeks, particularly Mycobacterium tuberculosis. Will take about 2 to 6 weeks before you'll be able to see visible growth. So, in order for the culture medium not to be dehydrated, okay, you need to place it inside a sealed bag. Alam niyo yung sealed bag, yung nilalagyan natin ng sandwiches, di ba merong sealed na ganon? So you can actually place that there. And then we also make the agar, we should also make the agar thicker so that it will not be dehydrated. Mycobacterium is enhanced also by the presence of 5 to 10% carbon dioxide. But Mycobacterium leprae fails to grow in vitro. Mycobacterium leprae is the causative agent of leprosy, and it will fail to grow in vitro. Okay, so that is for Mycobacterium. Okay, so the genus Mycobacterium is composed of approximately 100 recognized and proposed species. But among these, I think the most familiar for you is Mycobacterium tuberculosis. So Mycobacterium tuberculosis is the causative agent of tuberculosis. And another one that is quite familiar for you, we call it Mycobacterium leprae, the causative agent of leprosy, ketong in Tagalog. And other species would include non-tuberculosis mycobacteria. And sometimes these are also known as the MOTT, which stands for mycobacteria other than tuberculous. So here's another example of a photograph showing acid-fast bacilli. So how would you know if it's an acid-fast bacilli? Because of the color, red or pink. Okay, so that's the expected color. So these are the usual clinically significant isolated Mycobacterium. So we have Mycobacterium tuberculosis, bovis, and ulcerans. So Mycobacterium tuberculosis is the most common cause of tuberculosis Mycobacterium bovis is the source of BCG. Later on, I will be explaining that to you. What's a BCG? And then Mycobacterium ulcerans can cause ulcerations, and this one is also implicated among patients with AIDS. And there are several species, over 100 species of Mycobacterium. But for today, we will be focusing our discussion on Mycobacterium tuberculosis and later on Mycobacterium leprae. So historically, epidemiological changes led to challenges in the mycobacteriology laboratory. Imagine that it's quite difficult to determine its cause because of its unique characteristic. Okay, new developments in the field of clinical mycobacteriology are helping to meet the challenges and have resulted in rapid identification, particularly with the utilization of MALDI-TOF. So I've been always mentioning MALDI-TOF in every lecture that I have because it's a new technology in identifying bacteria. It's a game changer. Okay, and then of course, antimicrobial susceptibility testing is very important because we will be discussing later on that there are XDR-TB and then MDR-TB. These are multi-drug resistant tuberculosis and extremely drug resistant tuberculosis. But you know what? In most of the hospitals nowadays, um, they have the gene express that will help hospital quickly identify these particular resistant strains of Mycobacterium. So there are many advances of Mycobacterium comparing when I was still studying back in 1994. Imagine I was studying microbiology in 1994. You haven't even been born yet. So when I was studying microbiology, we didn't have even PowerPoint presentation back then, and these are just few pages. But nowadays, there are many developments. I am very eager to hear these developments with you. Nonetheless, in the United States, they say that the main pathogens would be Mycobacterium tuberculosis. And then we have another complex, the Mycobacterium avium intracellulare complex. This one is found in birds but may also be implicated as a pathogen. And then Mycobacterium bovis is the causative agent of cattle tuberculosis. But now they actually use this as the source of the BCG. Not usually seen in US because our textbook actually came from US, but leprosy is usually seen in some part of the country. In fact, in the Philippines, there is a particular area, leprosarium, in Tala, somewhere in Palawan. So it's actually an island where they kept people with leprosy for treatment and rehabilitation. Okay? And then Mycobacterium africanum is the causative agent of African tuberculosis. Okay? And Mycobacterium microti is not usually associated with human diseases. So to give you uh, ideas. So we will be focusing our discussion with Mycobacterium tuberculosis. I told you a while ago that Mycobacterium bovis is found mainly in cattle, but can infect other mammals, including humans as well. And then, luckily, they have included it to be part of the vaccination. So neonates, newborn infants, are usually injected with BCG, Bacillus calmette-guerin. So yung mga reason kung bakit meron kayong mga peklat dito, yung iba sa inyo meron. So it's actually due to your BCG. Okay? So Mycobacterium africanum causes tuberculosis in Africa. Mycobacterium microti is linked to tuberculosis among immunocompromised individuals. And children in Africa and patients with HIV in Africa will usually have Mycobacterium cannetti. Okay, Mycobacterium caprae Pinnipedi, Mungi, and Origis, all of them are implicated, infrequently associated with human infections. Okay, so let's talk about Mycobacterium tuberculosis. So this guy is Robert Koch. So he was the one who discovered Mycobacterium tuberculosis. And if you have time, you may want to read an article on how he discovered it, and you will be amazed with the story. Because among the different kinds of bacteria, Mycobacterium is quite difficult to isolate. And Robert Koch actually find a way to um, develop it or isolate it. And then, you know this one? Okay, so if you're not familiar with him, he is Manuel L. Quezon, okay, the second president and the first president of the Commonwealth. Okay, so Manuel L. Quezon um, died from tuberculosis. Imagine a Philippine president died from tuberculosis. Okay, because during his time, um, drugs against Mycobacterium tuberculosis have not yet been discovered. So he actually died from tuberculosis. So that's the reason why it is called as the Cox Bacillus and the captain of all men's death. The captain of all men's death. Because at that time, they haven't discovered yet, okay, drugs for tuberculosis. So commonly known as the human tubercle bacilli. And if you will be looking at the morphology, it is an acid-fast bacilli, long, slender, straight, or curved rod that would have the X, Y, V, and L arrangement, and they tend to grow in strand due to the serpentine cord factor. The serpentine cord formation is considered to be as the main virulence factor. It is considered as the main virulence factor for Mycobacterium tuberculosis. So why is it called the captain of all men's death? Because it is one of the oldest documented communicable diseases and remains the leading cause of morbidity and mortality. So it was first discovered in 1882 by Robert Koch, and it is estimated that 1/3 of world's population might be infected. And in fact, in 2014, they have estimated that 1.5 million TB-related deaths worldwide. And the reason? Well, one of the reasons is because of the presence of AIDS. So some people would usually die from HIV, from tuberculosis, because they are immunocompromised. Some of them would actually die because even with the presence of anti-tubercular drugs, but the strains that they got into are either XDR-TB or MDR-TB. Some of them would simply not take antibiotics at all. And that's sad because tuberculosis is treatable. Unlike other infections, but tuberculosis is treatable. So, but when you drink antibiotics, you usually drink it for 7 days and you're good, right? But since tuberculosis is a slow grower, it would need you to take it for at least 6 months. So the treatment is very long, and some patients uh, will not. Some patients are not faithful to the regimen, and if they're not faithful to the regimen, then they will not be treated. They will not be cured from tuberculosis. So Mycobacterium tuberculosis does not produce toxins. Unlike other bacteria that are considered to be as toxigenic, Mycobacterium tuberculosis does not produce toxins. Many determinants of pathogenicity is related to its unique cell wall. So there's a unique cell wall because of the presence of mycolic acid and the organism's ability to survive in phagocytic cells. So take note that Mycobacterium tuberculosis can multiply inside alveolar macrophage. alveolar macrophage is found in our lungs. And the organisms would have the ability to multiply inside the alveolar macrophage. So as what I've told you a while ago, the main virulence factor of Mycobacterium tuberculosis is known as the cord factor. So virulent strains of Mycobacterium, when in culture, appear to be like a serpentine cord. Whereas a virulent strains, so when you say a virulent, these strains are weak and not harmful. So for a virulent strain, they do not display the serpentine cord formation. So therefore, the serpentine cord formation is attributed to its virulence. And this phenomenon is related to a specific glycolipid. Okay? So the main component of this is known as the 5' trehalose. Okay, so that is the main component of the serpentine cord factor. So your 5' trehalose. So this compound is highly toxic to animals, although its role in human disease is not yet known. Okay, so that is the main virulence factor. So primary tuberculosis patients will have um, fever, fatigue, night sweats, weight loss, dyspnea, difficulty in breathing, coughing, chest pain, and hemoptysis. So when you say hemoptysis, patient will now start to cough out blood. And there are two types of lesions. So these lesions could either be exudative lesion and granulomatous lesion. We will be explaining that lesion later on. And there is also a possibility of having a secondary tuberculosis. So when you say secondary tuberculosis, a patient thought that he is already cured or healed, only to find out that there has been reactivation or reinfection. And then, if you will not be treating tuberculosis, it will become disseminated or extrapulmonary, or in some terms, we are calling it miliary tuberculosis. Okay, so these are the different kinds of tuberculosis. So let's discuss first the primary tuberculosis. So how do we get tuberculosis? The same way we get COVID-19. Okay, droplets. But they say also that tuberculosis could be airborne. Meaning to say, if you are in the laboratory and you are treating or you are processing samples with tuberculosis in benchtop, that is not very good. You have to process it inside the biosafety cabinet level 2. Otherwise, when you open the container, you can get the infection, particularly, especially if you are not wearing proper PPE. Okay? So once you get tuberculosis, cavities will open in the bronchi. So ito yung mangyayari, no? There would be hematogenous spread. So tuberculosis uh, will be ingested by alveolar macrophage. But they can still even multiply inside the alveolar macrophage. So when we do X-ray, you'd be able to see tubercle. It's like holes. It means that there are already cavities into the bronchi, and then this will allow the spread of Mycobacterium tuberculosis. So people with TB are infectious because whenever they cough, they can cough out bacteria like this. And if someone with tuberculosis is living in your house, okay, chances are people who are living with the same person will also get infected, especially children. So usually, hindi sa pinandidirihan natin sila, but they should have a separate utensil, and then they should always wear masks, and most importantly, they should be under antibiotic drug therapy. Okay? So 90 to 95% of infected individuals would have hematogenous spread. Okay? So some of patients would have reactivation after immunosuppression, HIV infection, or if they have been smoking. Okay? And this can result to cavitary tuberculosis. So dito na makikita that during X-ray, sasabihin ng doktor in layman terms, may butas ang baga mo. It's not literally a hole, kasi pag butas ang baga, patay na tayong lahat. But bakit nila sinasabi butas ang baga mo? It's because it is seen during the X-ray that it is as if that there are now cavities in the lungs because of these particular things that is happening. So, primary tuberculosis is transmitted by airborne, and it will infect deep lung in the alveoli. Bakit kaya gusto nila yung alveoli? Alveoli is our air sac, and it is rich in oxygen. And Mycobacterium is what? Obligate aerobic. So they need oxygen in order for them to grow. They need oxygen in order for them to grow. So at first, our alveolar macrophage will phagocytize them. But take note, they will continue to multiply. 4 to 6 weeks later, the T cells will sensitize and allow destruction of intracellular bacteria. There would be regression and healing of the primary lesion. But healing of primary lesion without antibiotic therapy doesn't mean that you are already cured, because slowly but surely, Mycobacterium are still multiplying. Okay, at this point, you'll be positive with the tuberculin skin test. So tuberculin skin test is an example of delayed type hypersensitivity reaction. You will be injected with PPD in your skin. PPD stands for purified protein derivative. And the reason why we call it delayed type, because the result will be seen after 24 hours, and we have to measure an erythema of more than 10 millimeter to be considered as positive. So the erythema should be more than 10 millimeter to be considered as positive. Okay. Take note also that tuberculosis is an example of chronic disease because of a long-term progression. Imagine it will take about 46 weeks before T cells can sensitize and allow destruction of intracellular bacteria. So it is indeed an example of a chronic disease with long-term progression. So again, this is what is happening in the lungs. So inside this lesion, you'll be able to see macrophages that are infected. Okay, so reactivation can occur as a result of advanced age, immunocompromise, and malnutrition. So what's the common denominator of these three factors? Common denominator is defective immune system. Okay, so that's the reason why there are some people who would have the reactivation. So primary tuberculosis as seen in X-ray, would have ito yung mga sinasabi kong cavitary lesions. But usually, we medtechs do not interpret this. It is the radiologist who would usually interpret it. So during the primary tuberculosis, during, for example, APE annual physical exams, you will have the routine chest X-ray, and then sometimes the radiologist would be requesting for lordotic view. Ah, when the radiologist would request for lordotic view, that's the time that he or she is trying to confirm whether the lesion is really due to tuberculosis or not. But of course, that particular data has to be supplemented with results of the laboratory test. Ayan. So kapag pinaulit yung annual PE, yung X-ray ninyo, tapos nakita ninyo na lordotic view, so most likely, it doesn't necessarily mean na may TB na kayo, but the radiologist is trying to confirm kung meron. Is it true? Iinom daw ng Bear Brand sterilized milk bago magpa-X-ray para ma-clear yung lungs? It's a myth, okay? Hindi yan totoo. Kasi may mga bata lang, lalo ng bata ako, magpapa-X-ray ka ba bukas? Sabi sa akin gano'n, papa-X-ray ka ba? Opo. Oh, uminom ka muna ng Bear Brand sterilized milk. Pag inom mo ng Bear Brand sterilized milk, bago ka magpa-X-ray, para malinaw yung yung X-ray film. No, that's not true. Okay, wag kayong papaniwala sa mga fake news na ganyan. That's not true, ha? So this is an exudative lesion of the lung autopsy. So kita nyo naman, there is already what you call a cheesy necrosis. Cheesy. Okay, a cheesy necrosis because of the fact that this is the lesion that is mostly made up of infected alveolar macrophages. Talagang there is already an ongoing inflammation in this particular area because of the severe infection. And then eventually, ito yon, granulomatous lesion. Kapag nag-hardened na yung lesion, from here, exudative, and then nag-hardened na siya, ito na yung granulomatous lesion. And this is the appearance of the tubercle. Okay? Microscopic appearance of the tubercle. So this is already made up of hardened tissue. Bakit hardened na yung tissue? Kasi nandito yung bacteria. Because our immune system is trying to contain them para hindi na kumalat. However, they keep on multiplying. They keep on multiplying until such time that the hardened tissue will break out and there is now a hematogenous spread and it will now become extrapulmonary. So kapag hindi nyo pala inagapan ang tuberculosis, there is a chance of it becoming extrapulmonary. Okay? So a while ago, you saw exudative lesion and this one is granulomatous lesion. So what's the difference? Exudative inflammation happens at the early stage because it is still an acute inflammation with edematous fluid, neutrophil alveolar macrophages surrounding the acid-fast bacilli. If these are the acid-fast bacilli, WBC are actually trying to contain them. Hence, you'll be able to see this one. Still in the acute inflammatory stage. Okay, so that is the exudative lesion. Later on, it will become granulomatous. So there is already a tubercle formation. It is a central area of giant cells containing tuberculosis, surrounded by a zone of epithelial cell and fibrous connective tissue. So it will make it harden because of the fibrous connective tissue. Okay? So this is now an example of tubercle formation. And these are the fibrous connective tissue. So this cheesy necrosis is called caseous necrosis. So it is actually the reason why it appears like this one because of because the excessive presence of the alveolar macrophages trying to contain the infection. So granulomatous lesion means that you are already at the chronic stage of the infection. Okay, so exudative lesion at the early stage because still an acute inflammation. So granulomatous lesion means that it is already at the chronic stage. Okay, so yan. So we do not want to have reactivation. So as what I told you, reactivation means that there is reinfection. And it usually happens as a result of alteration of the cellular immune response, okay, in infected hosts resulting in the replication of the bacilli and progression of the disease. So risk factors, I think I did mention this a while ago. And the common denominator is the suppression of immune system, advanced age. But meron na dagdag alcoholism, homelessness, because you are at risk daw of getting infection and incarceration. In prison pala, there is also a spread of tuberculosis in prison. Okay, so how do you know that um, tuberculosis is reactivating again? Say again, fever, shortness of breath, night sweat, chills, anorexia, and weight loss. Usually, guys, fever usually appears in the afternoon for someone with tuberculosis. So, nagtataka yung iba, bakit sa hapon lang ako nilalagnat? That's a sign of having tuberculosis. About 20% of individuals may have no symptoms, but they have cough, chest pain, and productive sputum. Chronic disease manifestation, ayan, fibrosis. Ito yung sinasabi ko sa inyo na fibrosis. Loss of lung volume, calcification, and PBD may be negative in 25% of the cases. So ano nga yung PPD? This is the skin test. Okay, so let's talk about diagnosis. What are we supposed to collect? For the diagnosis, we're supposed to collect sputum, gastric aspirates, and bronchoscopy specimen. Okay, so what if we will not be treating tuberculosis or there is a delayed diagnosis and treatment? So potential complications in any case of pulmonary tuberculosis, okay, so would be empyema. Mahirapan nga yung huminga yung tao. Pleural fibrosis, massive hemoptysis. When you say people will cough out blood, adrenal insufficiency, and hypercalcemia. Okay? So the less common would be extrapulmonary tuberculosis. So extrapulmonary tuberculosis happens in delayed treatment or untreated cases. In delayed treatment or untreated cases, there would be extrapulmonary tuberculosis, also known as the miliary tuberculosis, from lungs to bloodstream. And it will disseminate to other organs such as spleen, liver, bone marrow, kidney, adrenal gland, and eyes. And most of the time, it occurs in children and also in HIV positive patients. So it is correlated also with weak immune system. So that's the reason why treatment with tuberculosis is very important. Antibiotic therapy is available and it needs to start right away to prevent miliary tuberculosis. Okay, so what are the different organs? It could be at the genitourinary tract. So patients would have symptoms that are similar to urinary tract infection. And then skeletal tuberculosis affects the spine. So this one is known as the POTS disease because this will involve back pain and involvement of the hip and knee. So, ibig sabihin pala guys, biliary tuberculosis is the seeding. Kasi, we consider the lungs as the pulmonary tree. Diba? So, when the organism goes outside, it's actually considered as seeding. Usually occurs after primary tuberculosis with as a result of hematogenous spread. So, in pleural cavity, there could be effusion with mononuclear pleurocytosis of cough, fever, and chest pain. And then, sometimes people with biliary tuberculosis would have swollen lymph node. Yung kulani nila namamaga. So, painless head or neck swelling, usually in children and AIDS patients. So, usually, doctors would be collecting specimen from this swollen lymph node through FNAB. So, FNAB is also known as the fine needle aspirate biopsy. So, they would be collecting specimen through FNAB. And then yung POTS disease. Meningeal, meaning to say, it affects already the meninges. So, what does it mean? It means that from lungs, it goes to our blood, and then it passes through the brain, blood-brain barrier system. And as it passes through the blood-brain barrier system, it will now affect our CNS. So, there's a possibility that there is a meningeal form of tuberculosis. Meningitis from ruptured tubercle into the subarachnoid space. And there is also a mass-like lesion at the base of the brain. So a specimen for diagnosis for this one could be the CSF or the cerebrospinal fluid. For genitourinary tuberculosis, I think I did mention to you a while ago that there would be UTI-like symptoms. But for male, there is a male scrotal mass accompanied by renal tuberculosis. So mamamaga din yung scrotum ng mga males. So other varieties include gastrointestinal and peritoneal. Yan. So this is an example of a POTS disease. Kawawa, no? This child has POTS disease. Ibig sabihin, the spine is already infected with tuberculosis. So this is the TB of the spine. Lupus vulgaris is the TB of the skin. Okay, scrotula is the TB of the lymph node. Dito nag-FNAB yung mga pathologists. TB meningitis can result to paralysis. And this is the autopsy of a person who had renal tuberculosis. Can I excuse myself for 2 minutes? And so other causative agent of tuberculosis, which I have already mentioned to you. Again, let's review. Mycobacterium bovis is the causative agent of the bovine tubercle bacillus, and cattle are the usual reservoir. So we can get infected, we can get gastrointestinal tract tuberculosis in humans, particularly if we ingest unpasteurized milk from infected animals. And Mycobacterium africanum is somewhat intermediate between Mycobacterium bovis and tuberculosis, and obviously it is more common in Africa. Treatment. So the treatment is called a quadruple therapy. Do you know that if you will be if you will be drinking these anti-TB drugs individually, it will take you 2 years before you can finish the drug regimen. But because of the quadruple therapy, instead of 2 years, instead of 2 years, the treatment, the course of therapy will be reduced to 6 months. So, what are the possible treatment? Isoniazid, rifampicin, pyrazinamide, and ethambutol. If any of these is actually resistant, then streptomycin is another alternative antibiotic. So in the Philippines, we have the TB DATS Center. Okay, are you familiar with the TB DATS Center? So each rural health unit or each barangay should have a TB DATS Center. And DATS, okay, stands for Direct Observed Treatment Short Course. It is actually important in order to ensure patient compliance to drug regimen. So what's the purpose of the TB DAT Center? TB DAT Center should be located and accessible to people with tuberculosis. So usually what will happen is that patient will go to the DAT Center and they would need to drink the drugs there. Because before the installation of that center, people would be they would give out antibiotics for 1 month, let's say for 1 month, and then some people would tend to forget to drink antibiotics. Some of them would be selling the antibiotics, so the patient compliance to drug regimen would be very poor, and because of that, there would be extreme cases of XDR and MDRTV spreading. Because remember, if you will not complete, if you will not be completing the drug regimen for tuberculosis, what will happen is that uh, those organisms that were not killed because of antibiotics could become drug resistant. And if they could become drug resistant, then there would be more problem in the community. So that's the reason why they have actually instituted or installed TB DAT Center. So the next time around that you'll be able to see TB DAT Center, you know what is happening. And and of course, whenever they go to these places, you have to be careful, wear your mask, because most of the people who go there are actually infected and diagnosed with tuberculosis. But they are better as compared to people who are in the streets or who are lurking around the community who are undiagnosed and who are untreated. Mas okay na sila. At least they have already started the drug regimen. So, rifampicin inhibits uh, DNA-dependent polymerase. And then pyrazinamide will minimize relapse and shorten the treatment. So from 2 years, naging 6 months na lang. Ethambutol will inhibit the incorporation of mycolic acid into the cell wall, while isoniazid will interfere with DNA synthesis and inhibit the synthesis of mycolic acid. So as you can see, each of these drugs would have different action. But one of the reasons why people will not continue drinking anti-TB drugs is because of rifampicin. Rifampicin will make your urine orange, and it has to be taken on an empty stomach. And people will usually vomit if they're drinking rifampicin. So because of this adverse effect, they do not really want to drink rifampicin. But You need to educate them that these are some of the expected things, and they need to endure it for 6 months in order for them to be cured with tuberculosis. So these are the things that you really need to educate people with. So it says here, 9 months ang therapy if you are only drinking 2 drugs, isoniazid and rifampicin, magiging 9 months lang. But if you're drinking 4, it can be shortened to 6 months. So other possible choices are kanamycin and ciprofloxacin. So treatment failure is because of the patient's non-compliance and the presence of drug-resistant tuberculosis. I'll just be charging my laptop. Excuse me. Okay. And what are the two kinds of drug-resistant tuberculosis? So we have two multi-drug resistant tuberculosis, and the other one is extremely drug resistant tuberculosis. Excuse me. Okay. So when we speak of multi-drug resistant tuberculosis, means that they are resistant to second generation aminoglycoside and fluoroquinolones. And XDR-TB is resistant to the combination of several drugs. So the MDRTV is also known as the Vang's disease. So ibig sabihin, the organism is resistant to at least 2 of the most powerful first-line anti-TB drugs. For example, naging resistant sa isoniazid and rifampicin. So that is MDR-TB. And then XDR-TB means that it is resistant to isoniazid and rifampicin plus any fluoroquinolone and at least one injectable second-line drug such as amikacin, kanamycin, and capreomycin. Ito yung mga second-line drugs na injectable. Kapag resistant pa rin sila doon, aside from INH and RMP, ibig sabihin, the organisms that you have extremely malupit. XDR-TB na siya. If MDR-TB is hard to cure, more so with XDR-TB. So gene expert is actually there's a molecular test for that, and it's available in the laboratory. Yung may mga lab talaga na may gene expert to determine whether MDR and XDR-TB is present. So prevention, vaccination is usually being given to neonates. Ito nga yung Bacillus calmette-guerin. So it is the strain of live attenuated Mycobacterium bovis. So this one is very important. So unfortunately, medyo nagkakaubusan ito. When my baby was born in UMC, dapat pagka panganak pa lang, dapat meron na kaagad. But after 2 days pa siya nagkaroon. And then meron akong kakilala, after 1 month pa siya nagkaroon. You cannot give BCG to old babies because they have already been exposed to tuberculosis. You have to give BCG to unexposed neonates. Kaya nga siya tinawag na neonates. Ang ibig sabihin, bagong panganak. Meaning to say, they haven't been exposed to tuberculosis outside. So we need to give them BCG right away. Okay, safety consideration. Each employee is expected to have adequate safety equipment, trained in a safe laboratory procedure, and we should also inform them of hazard associated with procedure. For example, if you are going to centrifuge the tube containing sputum, you have to cap it. Otherwise, if there's no cap and you centrifuge the tube, organisms will float in the air. Okay, so the laboratory should have prepared action following unexpected accident, and they should be monitoring the employees regularly, such as by means of skin testing. So this is the ideal workflow for Mycobacterium laboratory. Mycobacterium laboratory should be separated from the rest of the laboratory because it is expected that there should be non-circulating ventilation system, meaning to say 6 to 12 room air changes per hour. And that particular room is also negative air pressure. Okay? And there is several negative air pressure so that the air will not be inhaled most likely and will not go outside. Okay? And we should also be working in the biosafety cabinet because this prevent aerosols. So when you centrifuge the tube, it has to be covered and it has to be done inside the biosafety cabinet. So we have this in our school. So this is called BSL level 2. So it should be properly installed and we have to calibrate it every 6 months. So if we're going to press it somewhere, it will have UV light incorporated with UV light and it will be, and also the surface should be disinfected as well. Okay, so and then we have to use proper disinfectant. So cover surface in towel or absorbent pad, soak in disinfectant because somehow this will reduce the aerosol. So what are the type of disinfectants? If you are working in TB lab, you should be prepared with the following, no? Phenol and soap mixture, sodium hypochlorite, ibig sabihin Clorox na diluted to, and then formaldehyde of between 3 to 8% and phenol solution of 5%. And then other precautions, we have to use a disposable loops and PPE should be complete. Okay, so this include gloves, lab coats, gowns, face masks, and respirators. Nowadays, most of the medtechs are trained on how to wear PPEs properly because they are using PPEs not just during working with TB lab, they're also using PPEs, especially nowadays in this time of pandemic, whenever they are collecting swab coming out from the patients or whenever they are processing swab for RT-PCR. So it is expected that we should wear PPEs. Okay. So what are the tests? Specimen. Okay, we can use expectorated sputum. So this is a sputum sample. You have to collect first morning sputum and and ask the patient not to submit saliva. Saliva is different from sputums because sputum should come should come from deep within they should deep coughing. There should be deep coughing. Hindi ko ma-demonstrate kasi wala naman akong sputum right now. But pag sinabing deep coughing, hindi lang yung nasa throat. Kasi kailangan makuha mo yung from the lower respiratory tract. Kaya deep coughing. Okay? And also, whenever you will be instructing the patients to collect sputum, it has to be first morning and they should brush their teeth or at least have a mouthwash so that you will not be collecting bacteria from the oral cavity. So they will be decontaminated. Or sometimes you can ask the patients to be in nebulizer with NSS so that it will be easier for you to collect the sputum. Or in some cases, they are using transcaeal aspirate, broncho, alveolar lavage, and laryngeal swab. And in some cases, they're also using FNAB. I think I've explained this to you already. Fine needle aspirate biopsy for swollen lymph nodes. So for swollen lymph nodes, they are using FNAB or fine needle aspirate biopsy. And for body fluids, we can also collect pleural fluid from the pleural cavity, gastric aspirate from stomach, especially if you are suspecting GIT TB, CSF, if you are suspecting cerebrospinal CNS infection or meningitis, stool and urine samples. Urine for genitourinary tuberculosis. So these are the different blood samples. So please do study box 26.2 of your Mahon book. Okay, so you can see that there are many specimens. So Most of these body fluids are used for extra pulmonary tuberculosis diagnosis or for miliary tuberculosis. Okay? Do you know that if you will be collecting sputum, what's the characteristic of sputum? Sputum is mucoid and sticky. And majority of the AFB, majority of the AFB will be trapped in the mucus. So unprocessed sputum will make your test less sensitive. And most likely, if it's less sensitive, it will result to false negative result. That's why we need to process the sputum. And there are two ways of processing the sputum. Okay? Digestion and decontamination. Don't get me wrong when you say digestion that you have to eat it. No, okay? When you say digestion, you have to use a mucolytic agent. And the purpose of mucolytic agent is to lyse the mucus so that we can liberate the AFP. And once we have liberated the AFB, it will be easier for us to see them under the microscope. Are you getting my point? So the point here is unprocessed sputum is less sensitive and will result to false negative because unprocessed sputum are mucoid and sticky, and you would expect that AFB will be trapped in the mucus. So to process the sputum, there are two processes. We can either do digestion and decontamination. So digestion means that we have to use a mucolytic agent so that we can lyse the mucus to liberate AFB. Decontamination means that we remove unwanted bacteria. So that's the purpose of decontamination. So the purpose of decontamination is to remove unwanted bacteria. Okay? So what are the things that we can do? So we can process the sputum using 2%, 3%, 4% sodium hydroxide. So this sodium hydroxide would serve as the contaminating agent and digestant at the same time. So 2-in-1 ang purpose. Okay, 2-in-1. NaOH will serve as the contaminating and mucolytic at the same time. 2-in-1. But yung NaOH and acetyl L-cysteine will only serve as liquefying or mucolytic agent, not necessarily the contaminating agent. Others are using benzalkonium chloride. It digests and decontaminate. Incidentally, if you're familiar with fogging machine being used to sterilize the room with for COVID-19 patients, okay, that is actually made up of benzalkonium chloride. So it serves as digestant and decontaminating agent. Oxalic acid is a decontaminating agent because this one is usually being used for sputum sample coming from patient with cystic fibrosis. Okay? Because patients with cystic fibrosis will usually have Pseudomonas aeruginosa. May I just answer my phone? Okay. Okay, so these are the digestion and decontamination agent. Okay. Concentration procedures. Why is it important? What do you mean by concentration? When you say concentration, this is the sputum sample. Okay? If this is a sputum sample, you would expect that Mycobacterium are elsewhere in the sputum sample. But because of concentration, it means that you would need to centrifuge the sputum sample, and Mycobacterium will be concentrated at the bottom or at the sediment. So what are the advantages of the concentration procedure? So concentration procedures are important because it will make the Mycobacterium easier to find, thereby increases sensitivity. And if sensitivity is increased, you prevent false negative. Okay, so that's the purpose of the concentration. Concentration simply means that you will need to centrifuge your sample. So it's because of the fact that Mycobacterium have low specific gravity, so they will not really settle down. And because of that, we need high speed centrifugation to concentrate. High speed, kapag slow speed, it takes longer and it will expose the bacteria to toxic chemicals longer, particularly important with large volume specimen. Okay? So concentration is also needed for the treatment of samples with mucolytic agents. Okay? So magpe-pellets ngayon yung bacteria. So bacteria will be concentrated. Okay? So that's the purpose of the concentration of the bacteria. Okay. So in the laboratory, we can diagnose TB by means of the following: direct microscopic examination, culture, tuberculin testing, biochemical testing, and antimicrobial susceptibility testing. So let's talk about first the direct microscopic examination. When you say direct microscopic examination, it means that we examine and look for TB, for Mycobacterium tuberculosis, okay, directly from clinical specimen. That's what we meant by direct microscopic examination. So I'm sure you will hear the term direct microscopic examination, not just in bacteriology, but in other courses that you are taking here in MLS as well. Okay, so you will hear the term direct microscopic examination. So again, direct microscopic examination is actually directly looking for the organism from the clinical sample. And the most common clinical sample would be sputum. And once we do direct microscopic examination, you can use two types of stain. If you are using carbolfuchsin, you are doing the acid-fast stain. If you are using fluorochromes, you are doing the fluorescent stain. Okay? And then the second one is culture. So there would be two types of solid medium. Would be the egg base and then the agar base. I will be explaining that to you later on. And then this is the liquid medium. Liquid medium is in the form of broth, and the purpose of such is for enrichment. Okay? So let's discuss them one by one. This one is actually released by DOH. This is the proper spreading of the smear. And smear is actually spread by means of repeated coil. So for example, that this is the inoculating, the applicator stick. Okay, it says here, select the purulent particle of the sputum specimen. Before fishing out the sputum, do not mix the sputum in the container because it may cause less probability of fishing AFB due to the less number of AFB in the sputum. So, for example, this is your slide, and you have to measure the area between 3 millimeter, 3 centimeter, sabi rito, 3 centimeter and 3 centimeter width. And then and then uh, and then the height is about 2 centimeter. Okay? And then spread a loopful of sputum in a clean glass slide uniformly in oval shape by smearing repeatedly in coil patterns 2 by 3 centimeter in size. Never make large smear because AFB may be scattered so much that it could lead to false negative and unusual numbers. So dapat yung area of examination is just 2 by 3 centimeter, tapos meron kayong imaginary oval. Tapos, coil. Magko-coil lang kayo. Mali daw yung paganto na spread, mali daw yung paganto na spread. So, dapat repeated coils. Tatagain nyo yan. Tatagain ninyo hanggang sa mapuno ninyo yung smear. And then, kapag meron na kayong coil, i-stain na ninyo using acid-fast stain. Kapag na-stain nyo na using the acid-fast, you now scan it under the microscope. So the proper way of scanning would be horizontal scanning and vertical scanning. The improper way of scanning would be zigzag scanning. So this one is not correct. Ito na mali pa. Okay? So, size too big or too small will most likely result to false negative. Uneven or slough off na smear would most likely result to false negative. Smear that is too thick or too thin will result to false negative. Dirt artifact will most likely result to both false positive and false negative. Saliva, hindi pala sputum yung sinubmit sa inyo, saliva pala, it would most likely result to false negative. How would you know kung saliva ba yung sinubmit ng patient ninyo or sputum? Usually, kapag saliva, marami kayong makikita na epithelial cells. Kapag sputum yung sinubmit sa inyo, dapat meron kayong makitang WBCs. Kasi, bakit may WBCs yung sputum? Because most likely, it is a result of inflammatory reaction. And whenever there is an inflammatory reaction, you would most likely see sputum sample. Kapag nag-overheat kayo ng carbolfuchine, it will result to both false positive and false negative. Insufficient heating of carbolfuchine, syempre hindi makakapasok yung carbolfuchine sa loob ng cell wall, false negative. Under decolorization, hindi tama yung paggamit niyo ng acid alcohol, it will result to false positive and false negative. Over decolorization, napasobra ang acid alcohol, it will result to false negative result. Okay, so that's why very important yung proper technique. Okay. Special staining requirement, gram stain is not being encouraged because of the increased lipid content. Bakit ba increase yung lipid content? Because of the presence of mycolic acid. Okay. That's why acid-fast stain is actually ideal. Okay, so in acid-fast stain, we are either using the Zil-Nielsen method, which I have already explained to you. It is the steam method. And the other one is the Quignon's method. This is the cold method because there's no heating. Okay, so that's the difference between the Zil-Nielsen and the Quignon's method. Okay, so I have explained this slide already to you during the introduction, so I will not be repeating it. Other methods of staining acid-fast would include Pappenheim's method. Pappenheim's method differentiates Mycobacterium lacticola from Mycobacterium smegmatis. These are actually commensals because Mycobacterium smegmatis is decolorized by rosolic acid in alcohol, and they are found in genitalia, particularly in uncircumcised male, yung mga whitish tingy dun sa penis ng male na uncircumcised, that is called smegma. In Tagalog, it starts with letter K, and I won't be mentioning it kasi it doesn't sound nice, but that is Mycobacterium smegmatis. Okay? Baumgarten's method differentiates Mycobacterium leprae from Mycobacterium tuberculosis. So Mycobacterium leprae is easily stained with diluted alcoholic fuchsin, coloring it red, while Mycobacterium tuberculosis does not readily take up the stain. So that is the Baumgarten's method. So this is an example of the Ziehl-Nielsen method. So you would see this is an example of non-acid-fast bacilli, because you'll see that it took up the methylene blue, which is the counter stain. This is an example of an acid-fast bacilli. So if you are using the Ziehl-Nielsen method, you would notice that the background is blue, while the acid-fast bacilli itself stains red or pink against a blue background. Okay, so you'll see that they are in beaded or in chain-like structure. And sometimes it's quite difficult to see them because sometimes they are hiding here, they are hiding here, they are hiding here. So it would really take a keen trained eye in order for us to see the acid-fast bacilli. Special stain would include auramine rhodamine dye, wherein Mycobacterium shall appear bright yellow or orange bacilli against a dark background. So this is a fluorescent stain, and you have to use an ultraviolet microscope. And Mycobacterium will glow in the dark. And it is actually more sensitive than the Ziehl-Nielsen method, but it's more expensive because you need to use a fluorochrome stain and you need to have an ultraviolet microscope for us to see the organisms. So Mycobacterium can be stained with fluorochromes. So these are the fluorescent dyes. So what are example of fluorescent dyes? Auramine and rhodamine. So these fluorochromes are specific for Mycobacteria, and the organisms appear orange or yellow against dark background. And this stain is used for screening procedure, and it is more sensitive than the acid-fast stain, but more expensive. So we grade also our smear. So there are several grading system that we can actually do. We can actually do +1, +2, +3, or +4. Okay, so this is carbon-fuchsin and acid-fast. So this would be the grading system. +1, if there are 0, our grade is 0 if there's no acid-fast bacilli seen. Our grade is doubtful, ±, if there are 1 to 2 acid bacilli for every 300 fields. What do you mean by fields? Every microscopic field is 1 field. And you need to have 300 microscopic field. Okay? Plus 1 if there is 1 to 9 per 100 field. Plus 2 if there are 1 to 9 per 10 fields. Plus 3 if there are 1 to 9 per field. And then plus 4 if there are more than 9 per field. Okay, so this is how we grade Mycobacterium. If you are using acid fast. But if you are using fluorochrome, it would be a different criteria. Fluorochrome. So, mas konti yung kailangan sa fluorochrome stain except for the plus 3 and plus 4 because plus 3 and plus 4, for plus 4, kailangan more than 36. Plus 3 is between 4 to 34. Okay, so most of the time we are using carbofuscin, not the fluorochrome stain because this one is more expensive. But for DOH, this is the National Standard Reporting Scale. So ito, galing to sa Mahon. But for DOH, according to DOH, 0 if no AFB is seen, plus N, 1 to 9 AFB per 100 visual field, plus 1, 10 to 9 AFB per 100 visual field, plus 2, 1 to 10 AFB per oil immersion field in at least 50 visual fields. So may mga ganun pang criteria, no? Then plus 3 if there are more than 10 AFB per oil immersion field in at least 20 visual fields. So this is the National Standard Reporting Scale of DOH. So in the Philippines, this is what we are following. Okay, so the manner of reporting, so you will give the result to the doctor as 0 plus N plus 1 plus 2 plus or 3 plus. So this is the manner of reporting in the Philippines. So how would you know if the specimen samples that you are receiving are sputum and not the saliva? I told you that if it's sputum, there are more WBCs. But if it's saliva, there are more epithelial cells. So you can do the scoring system. Okay? You can do the scoring system. You can score your specimen. So check first the number of neutrophils. If there are less than 10, you score it as 0. If there are between 10 to 25 neutrophil, it's plus 1. If there are more than 25 neutrophil, then that is plus 2. And then the next criteria would be the mucus. If the specimen is mucoid, you give it plus 1. And then the next criteria would be the presence of epithelial cells. If there are between 10 to 25 epithelial cells for every 10 microscopic field, you give it minus 1. If there are more than 25 epithelial cells for every 10 microscopic field, you give it minus 2. So you get the total sum, the sum. If the score is 0 or negative 1 or negative 2, less than 0, there is lack of inflammatory response. So you have just received a saliva. Do not accept the specimen. Ask the patient to repeat again if the score is 0 or less than 0. Okay? So do not accept the specimen. But if the score is at least 1, then you can accept the specimen. Okay, so that's clear. So do not accept saliva for AFB. We should be examining the sputum, not the saliva. Okay, so I will just be continuing our discussion next meeting. So next meeting, I will start in culture media kasi I need to go to, I'm currently, I will just stop the recording.